Welcome to the Deep Dive, where we unpack complex topics, cut through the noise, and give you the essential insights you need to be truly well-informed. Today, we're going to unravel the intricate story of breast health and disease, a journey from fundamental anatomy right through to the incredible precision of modern treatments. Our guide for this deep dive, a comprehensive surgical textbook packed with the latest medical understanding, helping us navigate this often sensitive and, well, deeply personal topic.
That's right. Our mission is to distill, decades of medical knowledge into understanding that empowers you. We'll explore surprising facts, clarify key distinctions, and reveal the real-world implications, helping you move beyond those quick headlines to a far clearer picture. Think of it as a rapidly evolving map of medical progress, and we're here to help you read it.
So if you're ready to get incredibly informed incredibly quickly, let's dive in. Let's start with the foundational architecture, breast anatomy, and its normal functions. What are some of the core components here that often surprise people, perhaps because they play a role later in disease?
What's truly fascinating, I think, is how the breast is built for both its primary function, milk production, and its structural support. You have the lobes and lobules where milk is made, sure. But then there are these vital internal guy wires called Cooper's ligaments. They stretch from the chest wall right up to the skin. And these are crucial because if a cancer grows and sort of pulls on them, it can cause that subtle dimpling or changes on the breast surface that can be an early warning sign.
Oh, okay. Dimpling.
Exactly. Also, there's a natural cushion of fat behind the breast, the retromammary fat pad, which creates a natural, relatively clear space between the breast tissue itself and the underlying chest muscles. This is important for surgeons as it helps define a plane of dissection.
So those tiny internal supports can actually give us critical visual clues.
Right.
What about the lymphatic system? We often hear about lymph nodes when discussing breast health, especially cancer. Why are they so central?
The lymphatic system is like the body's internal drainage network. And for breast cancer, it's a major pathway for spread. The vast majority, about 75% of the lymphatic flow from the breast, goes directly to the lymph nodes in the armpit. We call the axillary lymph nodes.
Okay, in the armpit.
Yes, and these nodes are grouped in different areas within the armpit, depending on their relationship to a specific muscle there. Understanding this precise drainage pattern isn't just medical trivia. It's a huge reason why breast cancer treatment has become so much more targeted and less invasive. It tells us where to look.
That makes perfect sense. And what about the delicate network of nerves and muscles around the breast and armpit? How do surgeons navigate these during procedures, and why is that precision so vital?
Oh, this is where surgical artistry meets detailed anatomy. It's really quite something. Surgeons work meticulously around crucial nerves that control arm movement and sensation. For example, there are nerves that power muscles essential for shoulder blade stability. And if these are damaged, it can lead to a condition called
Winged scapula, right.
where the shoulder blade sticks out. Exactly that, winged scapula, where it protrudes awkwardly. There are also sensory nerves that provide feeling to the arm and chest wall. Protecting these nerves as much as possible is paramount to prevent long-term issues like numbness or chronic pain, which is something patients are always counseled on. It's about preserving function, quality of life.
The human body truly is an intricate machine. Building on that structural foundation, it's also remarkable how dynamic the breast is. It undergoes profound changes throughout a person's life, from infancy right through to menopause. What are the most significant of these physiological shifts that listeners should be aware of?
Absolutely. It starts early. You see witch's milk in newborns, a small amount of milky discharge in about 90% of babies.
90%, wow.
Yeah, it's just a temporary effect from maternal hormones. Disappears on its own. Then puberty, or their LARSH, brings significant changes with increased fat and the development of milk ducts and glands, all orchestrated by a complex dance of hormones. During the menstrual cycle, breasts respond to hormonal fluctuations, often leading to temporary fluid retention, swelling, pain, and lumpiness in the days before a period.
That premenstrual tenderness and lumpiness people talk about.
Exactly. It's a normal, cyclical change, but it can understandably cause concern, as it might feel like a new lump. After menopause, the glandular tissue typically shrinks and is largely replaced by fat. However, hormone replacement therapy can sometimes affect this, occasionally increasing breast density again.
So many changes are completely normal.
Okay.
But let's talk about conditions that cause symptoms but aren't cancer. What about common issues like fibrocystic changes and breast pain? When should someone worry, and when can they maybe relax a bit?
Right. Fibrocystic changes are incredibly common, especially for women in their 40s and 50s. leading to pain, tenderness, and a generally lumpy or sort of ropey feel. Here's a crucial insight that often surprises people. Breast pain alone is very rarely a sign of breast cancer.
Really? That seems counterintuitive.
It does, but it's present in only about 7% of cancer cases. Pain is far more often cyclical, related to hormonal shifts, or sometimes it's even referred pain from other areas, like a muscle strain in the shoulder or back. Simple fluid-filled cysts are also common and almost always benign. Often, draining the fluid can relieve any associated pain.
Okay.
So while pain should always prompt a checkup, it's not usually the primary red flag for cancer.
That's a huge point of reassurance for many, I'm sure. If pain isn't the main red flag, what is the most common symptom that truly sends people to the doctor?
The most common symptom prompting a visit is a new lump or thickening. And while any lump warrants investigation, many turn out to be benign. For instance, fibroadenomas are the second most common breast tumor after cancer itself, especially in women under 30. They're usually benign, feel like solid, smooth, movable marbles, and are only rarely cancerous about 0.2% of the time. Often we just, observe these. Similarly, fluid-filled cysts are common, particularly in women over 35, and it's exceedingly rare for cancer to grow inside them. Unless they're causing significant discomfort or repeatedly return, surgical removal typically isn't needed.
And what about some of the less common but still notable benign developments like extra breast tissue or breast enlargement in men?
Right, accessory breast tissue, meaning extra breast tissue or nipples, can occur anywhere along what's called the embryonic milk line, which runs from the armpit down to the groin.
Milk line.
Yeah. These are quite common, sometimes mistaken for moles, and are usually only removed for cosmetic reasons. In men, breast enlargement, known as gynecomastia, is also common, particularly in teenage boys and older men. It's often benign and symmetrical, frequently resolving on its own, or linked to certain medications or other health conditions. The key is differentiating it from male breast cancer, which is much rarer and usually appears as a unilateral, asymmetrical, non-tender, fixed lump.
Got it. Nipple discharge can be very alarming for individuals. What should listeners know about that?
You're right, it can be very concerning, but nipple discharge from a non-lactating woman is actually rarely associated with cancer, only about 4–6% of cases if it's from a single duct.
Only 4–6%. Okay.
Yeah. The crucial distinctions are whether it's coming from one or both breasts, from multiple ducts or just a single one, and its color. Milky discharge from both breasts, known as galactorrhea, is usually benign and linked to elevated prolactin levels. However, unilateral discharge from a single duct, especially if it's bloody, definitely warrants a surgical evaluation. But even then, the most common cause for that type of discharge is a benign growth inside the duct called an intraductal papilloma.
Papilloma, okay. So if a patient finds something concerning or something feels off, what's the diagnostic process like from that initial visit onwards?
It begins with a comprehensive patient history. We'll ask about your age, reproductive history, any prior breast issues or biopsies, hormone use, and importantly, any family history of breast or ovarian cancer. This context is invaluable. Then comes a thorough physical examination, first with you sitting upright, where we carefully look for any visual cues like asymmetry, nipple retraction or inversion, or skin irritation. Even subtle dimpling, particularly when you move your arms, can be a sensitive indicator of an underlying issue.
Right, that dimpling again.
Exactly. And a critical sign to watch for is peau d'orange, literally orange peel skin, which is an unusual pitting or thickening of the skin due to swelling. This is a hallmark of inflammatory breast cancer and needs urgent attention.
Peau d'orange, urgent attention.
You got it.
That visual inspection sounds incredibly important, and then you move on to feeling the tissue.
Yes, exactly. After the visual check, we perform a careful palpation of both the breast tissue and the regional lymph nodes. For the breast, it's best done with the patient lying down, allowing us to compress the tissue against the chest wall. We're feeling for the size, shape, and consistency of any mass and whether it's fixed or movable. Benign lumps tend to be distinct, well-defined, and movable, almost like a smooth, slippery marble.
Like a marble.
Yeah. Carcinomas, on the other hand, are typically firmer, have less defined edges, and tend to feel like they're pulling or dragging on the surrounding tissue.
Okay. If a suspicious mass is found, a biopsy is often the next step. How has the approach to biopsies evolved over time? It's not just cutting things out anymore, right?
No, not at all. The evolution has been significant. Core needle biopsy, or CNB, is now the preferred method to sample breast lesions. Think of it like this. Fine needle aspiration, or FNA, is like using a tiny straw to collect a few cells for a quick look. CNB, however, is like taking a tiny core of tissue, a much more detailed sample, providing a full blueprint of the cells and their structure.
More tissue, better information.
Exactly. This gives doctors a much clearer picture, which is why CNB is preferred. It's often guided by imaging like ultrasound or mammography. FNA still has a role, especially for checking suspicious lymph nodes. Full surgical removal just for diagnosis, known as excisional biopsy, is much less common now because it's more invasive, costs more, and can delay treatment. It's usually reserved for cases where CNB results are inconclusive or for specific atypical findings. And for very small lesions, a tiny clip is often placed during the CNB to mark the precise spot, especially if treatment like chemotherapy is planned before surgery.
That distinction between the biopsy types is really helpful. Let's talk about imaging. Mammography is a household name, but how does it actually work to detect issues, and what are its strengths and maybe its limitations?
Sure. Mammography is the primary screening tool for women who don't have symptoms, aimed at finding cancers when they're still too small to feel. It uses gentle compression to spread out the breast tissue, which helps create a clearer image. While it's very effective, its sensitivity can be limited by breast density. In dense breasts, cancer can sometimes be hidden.
Hidden by the density.
Yes, and about 10–15% of clinically obvious cancers might not be immediately visible on a standard mammogram. Newer technologies like digital mammography and tomosynthesis, often called 3D mammography, have significantly improved things by creating multiple thin images, like slices, which help separate overlapping tissues, reduce false alarms, and find even smaller lesions.
So 3D helps see through that density better. Mammography is all about that crucial early detection then. What about other imaging techniques, and when are they used?
Well, ultrasonography is excellent for quickly determining if a lump is a solid mass or a fluid-filled cyst. It's also very useful for women with dense breasts because it doesn't use radiation and can see through that dense tissue.
But not for general screening.
Generally not. It's operator dependent, meaning it relies heavily on the skill of the person performing the scan, and there aren't standardized protocols for broad screening like there are for mammography. MRI, or magnetic resonance imaging, is another powerful tool. It has a very high sensitivity, meaning it's great at detecting invasive cancer.
There's always a but, isn't there?
Well, yes. It also has a moderate specificity, which means it can pick up more false positives compared to mammography or ultrasound, things that look suspicious but turn out to be benign. So MRI is particularly useful for high-risk screening, like for individuals with BRCA gene mutations, for assessing the full extent of a known tumor, or for monitoring how a tumor responds to chemotherapy given before surgery. We use a standardized system called BI-RADS to categorize imaging findings, with scores ranging from 0 for incomplete to 6 for a known malignancy. A BI-RADS 3, for instance, means the finding is probably benign, less than a 2% chance of being cancer, and is typically just watched over time.
Okay, BI-RADS 3, probably benign. That's useful to know. This is where we get into crucial preventative information. What factors significantly increase someone's risk for breast cancer?
Age and gender are arguably the most fundamental risk factors. Breast cancer is very rare before age 20, but rises steeply with age. By 80, a woman's lifetime risk is approximately 1 in 8.
1 in 8 by age 80.
Yes. While breast cancer in men is uncommon, accounting for less than 1% of cases, it does occur and often shares similar characteristics. Also, a personal history of breast cancer means an increased risk of developing a new primary cancer in the other breast.
So age and gender are givens, but what about other, perhaps less obvious factors that might show up on a biopsy result, for example?
That's an excellent point. Certain microscopic findings in breast tissue, like lobular carcinoma in situ, or LCIS, and atypical ductal or lobular hyperplasia, ADHALH, are significant risk factors. LCIS, for example, is no longer considered a cancer itself, but rather a powerful marker that indicates an increased risk of developing invasive cancer in both breasts.
Both breasts. Interesting.
Yes. And we know that a 5-year course of a medication like tamoxifen can reduce this risk significantly by over 50%. These atypical proliferations, ADH and ALH, are collections of unusual ductal cells that can increase someone's overall breast cancer risk by 4 to 5 times.
4 to 5 times. Okay. Here's where the puzzle truly deepens. Genetics. How do mutations in genes like BRCA1 and BRCA2 play a role, and what are their implications?
Genetics account for a smaller percentage overall, about 5–10% of all breast cancers, but that jumps significantly to up to 25% for women diagnosed under 30. BRCA1 and BRCA2 are what we call tumor suppressor genes. Think of them as the body's own genetic police, constantly patrolling and fixing DNA damage.
The repair crew.
Exactly. When these genes have a mutation, that protective mechanism is compromised, leading to a much higher lifetime risk of developing breast cancer, between 50–70% for carriers. Critically, these mutations also significantly increase the risk of ovarian cancer. What's also fascinating is that BRCA1-associated cancers tend to be more aggressive, often what we call triple negative, meaning they lack the common hormone receptors,
Triple negative, we'll come back to that.
while BRCA2 cancers are more frequently hormone receptor positive.
So the genetic signature can actually influence the type of cancer. What about everyday factors related to lifestyle and hormones?
Factors that increase a woman's lifetime exposure to estrogen can modestly increase risk. This includes things like starting menstruation very early, before 12, having a first full-term pregnancy after age 30, or never having given birth. Conversely, breastfeeding has been shown to reduce risk.
Okay.
Regarding exogenous hormones, a large study called the Women's Health Initiative found that combination hormone replacement therapy, estrogen plus progesterone used for 5 years, was associated with a 20% increased risk of breast cancer.
Combination HRT.
Yes. However, estrogen-only HRT did not show a similar significant increase in risk in that study.
Given all these risk factors, what are the current strategies for care for someone identified as high risk? What do you do?
For individuals with a calculated 5-year risk of 1.66% or higher, the options typically include intensified surveillance with regular clinical exams, mammography, and importantly, an annual breast MRI.
More frequent checks, basically.
Yes, and closer checks. Another strategy is chemoprevention, which means taking certain medications like tamoxifen, raloxifene, or aromatase inhibitors. These drugs can significantly reduce the risk of developing breast cancer, particularly for hormone receptor-positive types, though they do come with their own potential side effects that need careful discussion.
Of course. And for those with very high genetic risk, like BRCA mutation carriers, what about the option of prophylactic or preventive surgery?
That's a significant consideration for those individuals. Prophylactic mastectomy, surgical removal of the breast before cancer develops, can reduce breast cancer risk by as much as 90%.
90% reduction, that's huge.
It is. Similarly, risk-reducing removal of the ovaries and fallopian tubes, called salpingo-oophorectomy, significantly reduces both ovarian and breast cancer risk and can improve overall survival for BRCA carriers. These are profound, life-altering decisions, and extensive counseling is absolutely crucial to help patients understand all the implications.
Absolutely. Let's shift now to breast cancer itself. Once diagnosed, what are the main types and how do we begin to classify them today?
Broadly, breast cancers fall into 2 categories: non-invasive and invasive. Ductal carcinoma in situ, or DCIS, is a non-invasive precursor. Here, the malignant cells are still contained within the milk ducts.
Like trapped inside the pipe.
Exactly, trapped inside the pipe. If left untreated, it has the potential to become invasive cancer. Invasive ductal carcinoma, IDC, is the most common form. These cells grow as a cohesive, solid mass. Invasive lobular carcinoma, ILC, on the other hand, is different. It tends to spread through the breast in a single-file pattern, almost like individual cells marching in a line, which can often make it harder to detect on imaging or even feel.
So it's not just about ductal or lobular. How do we get to the level of personalized medicine that we hear so much about today, the specific treatments?
Right. This is where we really begin to decode the cancer's specific identity. We classify them by molecular markers: the estrogen receptor, ER, progesterone receptor, PR, and HR2, or human epidermal growth factor receptor 2. Think of cancer cells having different locks on their surface. ER and PR are like one type of lock, and HR2 is another.
Locks and keys.
Pretty much. These markers are routinely tested because they tell us if we have a key, a targeted therapy, that can fit and disrupt that specific cancer's growth. For instance, if a tumor is ER positive, it means it has that estrogen lock, and we can use endocrine therapies to block estrogen's growth-promoting effects. If it's a 2-2 positive, we have HER2-targeted therapies like trastuzumab that can dramatically improve outcomes.
So it's not just the size or spread, but its unique biological signature that dictates treatment.
Precisely. Tumors that lack all 3 of these locks, ER, PR, and HER2, are called triple-negative breast cancers.
Ah, there it is, triple negative.
Yes. These often overlap with what we call basal-like cancers, which are typically more aggressive and, interestingly, more common in BRCA1 mutation carriers. Modern classification takes this even further with multi-gene assays like Oncotype DX or MammaPrint. These tests analyze panels of genes from the tumor to predict how likely the cancer is to return and, crucially, whether chemotherapy will provide a significant benefit.
So you can potentially avoid chemo.
Exactly, especially for ER-positive, node-negative cancers. The TAILOR-X trial, for example, famously showed that many women with intermediate recurrence scores could effectively be treated with hormone therapy alone, sparing them the harsh side effects of chemotherapy.
Amazing. And what does staging mean for breast cancer? Is it still just about tumor size?
Staging is critical. It creates a comprehensive picture of the cancer's extent, allowing us to group patients into risk categories to define their prognosis and guide treatment. The traditional TNM system, tumor size, lymph node status, and presence of metastasis, has been updated quite significantly by the AJCC. It now incorporates not just these anatomical features, but also the crucial biological markers like ER, PR, HR2 status, and even those oncotype DKIC scores we just discussed.
So staging itself is becoming personalized.
And very much so. This layered approach truly reflects our modern understanding of how tumors behave and how best to personalize care.
Historically, breast cancer surgery was, well, notoriously extensive and disfiguring. How has that approach dramatically changed over the decades?
Real dramatically is the word. The Halsted radical mastectomy, which involved removing the entire breast, the skin, the underlying chest muscles, and all the armpit lymph nodes, was the standard treatment well into the 1970s. It was a brutal surgery.
Hard to imagine now.
It is. But a revolution occurred with the advent of multimodality treatment, combining surgery with radiation and systemic therapies, and the ability to detect cancers much earlier. The truly groundbreaking insight came from large randomized trials in the 1980s, like NSEBP-B06 and Milan-I. They showed there was no survival advantage for a full mastectomy over breast-conserving therapy, often called a lumpectomy, followed by radiation.
No survival difference.
None in terms of overall survival. The lumpectomy removes only the tumor and a small margin of healthy tissue. This was a paradigm shift that completely changed breast cancer care, allowing many women to keep their breast.
So patients often have a choice between a mastectomy and breast-conserving therapy, BCT, with equivalent long-term survival rates. What factors go into that deeply personal decision?
Patient preference is absolutely paramount. Beyond that, the decision hinges on factors like the tumor size relative to the breast size, whether surgeons can achieve clear margins, clean edges around the tumor, and if there are any medical reasons preventing radiation therapy.
Like pregnancy.
Like pregnancy, or certain connective tissue diseases, yes. Also, a rapidly growing field called oncoplastic breast surgery has emerged. This uses plastic surgery techniques like tissue rearrangement or breast reduction to achieve the best possible cosmetic result after a lumpectomy, especially for larger resections or tumors in complex locations. The goal is excellent cancer control and optimal aesthetics.
And for a full mastectomy, are there still specific indications today? When is it still the recommendation?
Yes, certainly. A mastectomy is still recommended for large tumors that are too big for breast conservation, for extensive calcifications throughout the breast, if clear margins cannot be achieved with a lumpectomy, or simply if it's the patient's strong preference. If immediate breast reconstruction is planned, we can often perform a skin-sparing or even nipple areola-sparing mastectomy. This preserves more of the natural skin envelope or even the nipple, providing a much better foundation for reconstruction, and studies show it can be oncologically safe.
We mentioned lymph nodes earlier as key indicators of how cancer might have spread. How has the surgical approach to lymph nodes evolved to be less invasive? That seems like a huge area of change, too.
It really is. Historically, a complete axillary lymph node dissection removing all the armpit lymph nodes was standard, but it's a major source of long-term complications like lymphedema.
That chronic arm swelling.
Exactly. Horrible chronic arm swelling, numbness, and reduced arm mobility. The truly revolutionary breakthrough has been sentinel lymph node dissection, or SLND. Here, surgeons inject a blue dye or a radioactive tracer to identify and remove only the first node or nodes that drain the tumor site, the sentinel nodes.
The guardians.
Sort of. You could say that.
Yeah.
If these sentinel nodes are negative for cancer, the likelihood of other nodes being involved is incredibly low, allowing us to spare patients the full, more extensive lymph node dissection and its harsh side effects.
That sounds like a massive benefit for patient quality of life. But what if that sentinel node is positive for cancer? Is a full dissection still always necessary then?
This raises a very important question, and it was the subject of another huge paradigm shift. For many years, a positive sentinel node automatically meant a full axillary dissection. But a landmark study, the ACOSOG 0011 trial, showed that for patients with early-stage breast cancer undergoing breast-conserving surgery and whole breast radiation, even with 1 or 2 positive sentinel nodes, a full axillary lymph node dissection could safely be omitted.
Safely omitted, even with positive nodes.
Yes, in that specific context, early stage, BCT, radiation, only 1 or 2 positive nodes. This was groundbreaking because it proved that for a significant group of patients, we could avoid that major surgery without compromising their overall survival or disease-free survival. It truly changed how we manage lymph nodes.
That's incredible. Is there anything further being done to reduce the risk of lymphedema, even in cases where a more extensive dissection is necessary?
Yes, there is. What's fascinating here is the development of axillary reverse mapping, or AR.
Reverse map.
Yeah. By injecting a blue dye into the arm itself, surgeons can, during the operation, identify and try to preserve the lymphatic channels that drain the arm. The hope is that by protecting these crucial arm drainage pathways, we can further reduce the risk of lymphedema even when a more complete lymph node dissection is required for cancer control. It's another step towards minimizing the impact.
So surgery removes the visible tumor. But what about microscopic disease that might be lurking elsewhere or preventing recurrence? That's where additional therapies come in, right? Radiation, drugs.
Precisely. That's where radiation therapy and systemic therapies play their vital roles. For patients who undergo breast-conserving surgery, adjuvant whole breast radiation is critical. It significantly reduces the chance of the cancer returning in the same breast and improves long-term outcomes. We're also seeing advancements in shorter treatment courses, like partial breast irradiation, PBI, which focuses radiation directly on the original tumor bed.
More targeted radiation.
Yes. And for higher-stage cancers, particularly those with 4 or more positive lymph nodes, radiation to the chest wall after mastectomy is also crucial and has been shown to improve overall survival.
And then there's systemic therapy, like chemotherapy or targeted drugs, which aims to treat the whole body, get anything that might have escaped.
Exactly. Systemic therapy is designed to treat or prevent microscopic metastatic disease throughout the body. Chemotherapy, using powerful drugs like anthracyclines and taxanes, has been proven to significantly reduce recurrence and mortality. Although it does carry risks like heart damage or nerve issues, neuropathy,
Right.
the story of HR2-based targeted therapies, like trastuzumab, is a true revolution. For HER2-positive cancers, these drugs have dramatically improved survival rates, often used in combination with chemotherapy.
And hormone therapy, that's also a systemic treatment, isn't it? Blocking those receptors we talked about.
Absolutely. Endocrine therapy, like tamoxifen for ERPR-positive cancers, is one of the original and most successful targeted therapies. Tamoxifen works by blocking the effects of estrogen on cancer cells and has been shown to reduce recurrence and death in both pre- and postmenopausal women. Aromatase inhibitors, or AIs, are another class used specifically in postmenopausal women, which stop the body from making estrogen elsewhere, further improving outcomes. We're even seeing studies explore longer durations of these therapies, with some guidelines now recommended up to 10 years for certain patients.
10 years of hormone therapy.
Potentially, yes, for some high-risk individuals. And an increasingly common strategy today is neoadjuvant systemic therapy, meaning treatment before surgery.
Right, neoadjuvant. What are the key advantages of giving therapy before surgery?
There are several powerful advantages. First, it can shrink large tumors, potentially making a patient who would have needed a mastectomy eligible for breast-conserving therapy, or leading to a better cosmetic result for a lumpectomy.
Downsizing the tumor.
Exactly. Second, it gives us an invaluable opportunity to see how the tumor responds to treatment in vivo, in the living patient. If a patient achieves a complete pathological response, meaning no residual tumor is found at the time of surgery, it's strongly correlated with improved long-term survival, especially for more aggressive subtypes like triple-negative or HER2-positive cancers. This direct observation helps guide future treatment decisions.
So you know if the drugs are working before you even operate.
Precisely. And it's important to note that a small metallic clip is placed to the original tumor site before treatment begins, so surgeons can precisely locate the area for later removal, even if tumor shrinks completely and can no longer be seen or felt.
Ah, the clip marks the spot. Makes sense. Finally, let's briefly touch on some special circumstances and how treatment might adapt. How does breast cancer treatment differ for older adults, for example? Is it always the same?
Not always. For older women, particularly those over 70 with smaller hormone receptor-positive tumors, studies have shown that lumpectomy followed by endocrine therapy alone, without radiation, can achieve similarly high survival rates. This allows for a less burdensome treatment regimen, prioritizing quality of life for a population that may have other health considerations.
So sometimes less is more in terms of treatment burden. And what about Paget disease of the nipple? That sounds quite specific.
It is. Paget disease is a rare type of malignancy that presents as an eczematoid rash-like appearance on the nipple. Looks a bit like eczema. It's crucial to recognize because in over 95% of cases, Paget disease signals an underlying breast carcinoma, which could be DCIS or invasive cancer.
So the rash is a sign of something deeper.
Almost always. So a biopsy of the nipple itself is absolutely essential. Treatment can range from mastectomy to a more localized removal of the nipple and areola with radiation, depending on the extent of the underlying cancer.
We also briefly mentioned breast cancer in men earlier. Can you expand on what listeners should know about it? It's rare, but it happens.
Exactly. While rare, accounting for less than 1% of all breast cancers, it's very important to recognize. The median age at diagnosis is typically around 68, slightly older than in women. Key risk factors include increasing age, prior radiation exposure, and certain genetic predispositions, particularly BRCA2 mutations. Interestingly, gynecomastia, or benign male breast enlargement, is not considered a risk factor for male breast cancer.
That's important to clarify.
Yes, most cases are invasive ductal carcinomas, often hormone receptor positive, and the treatment options are generally similar to those for women, always tailored to the stage and the tumor's specific characteristics.
This deep dive has truly unpacked the complexities of breast health and disease, from, well, microscopic anatomy all the way to the profound impact of personalized therapies. We've heard how far we've come, with survival rates steadily improving over decades thanks to earlier detection and just incredible advances in treatment.
That's right. The journey from radical, often disfiguring surgeries to breast-conserving and targeted risk-reducing strategies, driven by a deeper understanding of tumor biology, is nothing short of remarkable. The continuous evolution in diagnostics, like sophisticated imaging and genetic testing, coupled with the development of truly individualized therapies, is allowing for increasingly tailored and, frankly, more effective care.
So, what does this all mean for you, the listener, taking all this in?
Well, this exploration of medical progress raises, I think, an important question for everyone. Given the rapid pace of discovery we've explored today, how do you imagine our understanding of breast cancer will continue to transform treatment and prevention in the next decade? What new biomarkers or technologies do you foresee emerging that could further personalize care and perhaps even lead to a shift from treatment towards cure for an even broader range of patients?
A truly profound thought to ponder as we look to the future. Thank you for joining us on this deep dive. We hope you feel more informed, less overwhelmed, and perhaps even a little more curious about the incredible journey of science within the human body.